Moving on to bridging the gap, essential care by general practitioners before nephrology referral. For this, may I request Dr. Sagar Kulkarni, sir. He's an MD Medicine, DNB Nephrology. He's a nephrologist and a kidney transplant physician. He practices at Tulip Healthcare Clinic, KEM Hospital and Manipal Hospitals. Welcome, sir. Inviting Dr. Shirish Jadhav, sir. He's a BMS Senior Family Physician, practicing for more than 4 decades. Welcome, sir. Please join me in welcoming the chairpersons. Requesting the chairpersons to please introduce the speaker.
Dr. Suhas Mondhe, sir. Welcome here.
Thank you.
On BMA for 2024. Hello. Good morning, all. Dr. Suhas Mondhe, sir. At present, he is a consultant nephrologist in well-known hospital, Eurocol Hospital. Dr. Suhas Mondhe, sir, DNB Nephrologist, Care Hospital, Hyderabad. Fellowship in Solid Organ Transplantation, University of Ottawa, Canada. DRC PCS, Diploma of Royal College of Physicians and Surgeons of Canada. Appreciation by American Society of Transplant. Fellowship of Gluconephritis, University of Ottawa, Canada. This is एक मानाचा तुरा समजला जाईल तुमच्या बाबतीत सर. After then, Hematodialysis Fellowship, London Nephrology Department, University of Western Ontario. So there are so many achievements about Dr. Suhas Mondhe, sir. So I request Dr. Suhas Mondhe, sir, to deliver your lecture. We will like to hear it. Thank you, sir. Thank you very much. Thank you.
Thank you. A very good morning to all of you, and thank you for the committee to given me a chance to represent me and kidney both. The topic I chose is so that I'll be more interactive with everyone, and if at all I can help each and everyone to understand how better we can take kidney patients' care. Okay, so before I start my discussion, before I start even my disclaimer, I would like to show this. So even though patients go to multiple specialties, multiple consultants, they always need to be synchronized by one person. And most of the time that job is done by the doctor who patients get into first contact. So family doctor or general practitioners or probably someone in the family who is closer to the patient, and patient's family who knows the patient's finances, patient's emotions, patient's stresses, burdens, everything in detail, probably the person who can do this job in a better way. So that's why I thought that before referring the patients to the nephrology, what all care they can start or they can initiate, that will be probably a good top for the discussion. So disclaimer is that I'm here to represent kidneys. So in this presentation, in next half an hour, probably you'll see some characters, some photos, probably which are not needed for this presentation, but they are there just to have more interaction between us. Okay. So what is the job of the primary or the first contact physician? First of all, they know the patients better. They know the history of the patient. They know the even family history. They can identify the early signs of organ involvement like kidney, heart, and any other systemic involvement. They can identify the red flags in a early way so that they can refer the patients to the particular specialist in timely manner. They are most helpful for regular monitoring so that they can keep a check on the lab work, patient's well-being, early symptoms. They can discuss with the patient what the disease could be progressing and how the patient should be following with the restrictions and monitoring parameters. And they will be always involved, probably they are having more share in patient's better outcome also. As compared to that, whenever the patient comes to nephrologist, and Sagar is here, he also will understand this. Taking nephrology opinion doesn't happen in one go. We need to give multiple attempts, multiple unsuccessful attempts, and then only one time patient will understand what we are trying to express. And at that time, probably patient starts taking the advices in a more serious way. So before we conclude, if the patient's family doctors or the general practitioners, where they are like in more contact, if they can start telling about the kidney disease, that will be better for us also. Stage तयार करतो म्हणतो ना आपण कुठल्याही परफॉर्मन्सच्या आधी, that helps for our discussions to start building. So I'll start with the one question. How many of hypertensive patients are having blood pressure controlled? Anyone guesses? There are 4 options, A, B, C, D. So no Karodpati contest here, but at least anyone can try. What could be? Hypertensive patients with a controlled blood pressure. 20%. Someone said 20. 25. 25%. Okay. Most of you have not attempted MCQs recently, probably. Always the odd figure could have been the answer, but in this case the answer is A. There is hardly 12% of the hypertensive patients are having controlled blood pressure. And that's because even though we are having like very high prevalence of hypertension, of those, if 100% patients are there, only 28% are aware of it. Of those, hardly 14-15% are on treatment, and those who are actually having controlled blood pressure is hardly 12 to 13. So answer was A, and the remaining are all at risk of developing the kidney disease. So we need to be like more involved into their discussion so that we can take better care of them. This is also called as the iceberg phenomenon, that whatever we are seeing is just the tip of that iceberg, and so many of them we are not yet even reached out so that we can treat them or help their kidneys. There is a difference between us and the Western population. Our hypertensives are a little bit different. Obviously, Indians are a little bit special, right? So, first of all, we are having more salt sensitivity. Patients are having more sympathetic overdrive. That could be because of high RAS. We are even constantly dehydrated also. There is a high percentage of low birth weight babies, which gives like a theory or the idea of low nephron mass, which makes them more prone for the hypertension. We are having a very high percentage of diabetes also, which eventually will overlap with our patients. We have seen early onset of hypertension. Nowadays we are seeing in 20s or probably even earlier than that, first, second decade or so. We are having other multiple risk factors also, like obesity. We are having very high consumption of tobacco. And whenever there is an early kidney damage is seen, we need to have we see like poor control of the CKD progression. We do see that they are not adequately treated. And even though they come for the treatment, they are not adherent to the treatment, what they should be follow. So complications of hypertension, I can put it in 2 ways. Either this is a catastrophe which is happening at the moment of brief moment of time, like bleed, IC bleed, cardiac failure, or that could be like a chronic trouble which needs like more attention, and the control of blood pressure can save both of them. We can get more history from the patient, and that should be something that we should be following during their lifestyle. What is their lifestyle? Smoking, obesity, what are their exercise capacities, how physically active they are, neurologically, what all headaches, blurring of vision, what symptoms they are seeing, cardiovascular, most probably regularly followed by the patients that they reach out to a specialist or the cardiologist with the smaller cardiac symptoms also, palpitations and breathing difficulty, but they tend to neglect most of the renal history, like swelling over the legs, seeing froth in the urine or blood in the urine, everything. There are many facts which we can consider regarding the hypertension. First is obviously white coat hypertension. डॉक्टरांकडे बघितल्यानंतर किंवा डॉक्टरांच्या क्लिनिकमध्ये आल्यानंतर ब्लड प्रेशर वाढतं. That is not abnormal. That is definitely a entity which is mentioned. But there are other entities also, like a mast at patients' work hours or during the offices if the blood pressure is high, and they come to doctor and it gets like normal or looks controlled. Probably we'll miss those patients, and those patients could have like worsening kidney disease. Non-deepers, आपण झोपल्यानंतर BP ड्रॉप व्हायला पाहिजे. That's a physiology that proves that we are getting a good sound sleep. But if someone is not having that drop, probably they are at risk of more worse outcomes of the hypertensions. Salt sensitivity. जर आपण कॅल्क्युलेट केलं तर आपलं सगळ्यांचं सॉल्ट इंटेक वी कॅन फाइंड आउट इट्स टू हाय, and that increases the risk of hypertension in us. Refractory blood pressure, despite of 1, 2, 3, 4 drugs also, diuretics added on top, can still not sufficient to control the blood pressure, and that is something that we need to understand, that there could be a factor which is not well taken care. That could be a secondary causes which are underlying, endocrine causes, cardiac causes, or some medicines, and we need to find out so that we can take better care of them. There is pseudo hypertension. If the blood vessels are so thick that even with the cuff it is getting inflated at too high number, it's not still able to compress that blood vessel, and we probably keep on increasing the blood pressure medications, but that is not sufficient to take care of that. There was a paper, and that mentions from probably 2010 that the salt sensitivity and health of Indians, that more the salt intake, obviously the more prevalence of uncontrolled hypertension, which will lead to the progression of the kidney disease. And this paper, if you can see, was mentioned in 2010. But do we really think that we are aware of the salt and blood pressure from 2010, or we are probably aware it for long? Right? Sholay came in 1975. Since then we are knowing that सरदार का नमक खाया तो गोली भी खाना पड़ता है, right? So we are not needed any medical or like ethical paper which can say that hypertension and the salt intake go hand in hand. There are so many salts nowadays. When we started nephrology, probably that at that time there was only one salt, and we get this question too often, which one is better? And the answer is simple: yes, they are all different and they are all same. So even though we are seeing them with the different colors, shapes, sizes, the saltness is the same. They are still salty and they are still affecting the kidneys. There are very commonly, I recently learned that LSM, last time, lifestyle modification word I understood, but how many of our patients really do that? The reason that they don't do it, that's the reason they are patient to us, right? So every time whenever a patient comes to us, we need to emphasize that they should be having active life. First of all, they should be losing weight, and even though it's too hard to lose a weight, still they should try. And what all methods they can try to have some good relaxation, pranayam, yogasan including. Whether the hypertension is the only sole culprit for the damage, probably not. There are multiple enemies that we see: diabetes, obesity, pain medications, dehydration, and all of them affect the patient's kidneys at one time. It's not that first hypertension affects and then the diabetes comes and then dehydration. Probably not, right? So we need to tackle each and every trouble or problem that patient is having at one go. And if we are not doing, then probably we are able to just partially treat the kidneys and remaining are still getting affected. Anyone can help me out with what is the costliest treatment for the patient? Sorry? Regarding anything which is the costliest bill for the patient. Cancer, someone said cancer. PTCA? Okay. Nowadays, there are things more costlier than that. LVAD, heart transplant, anything like. So I was expecting those options also. Kidney transplant, okay, but not much. Sorry? Depends on the hospital, yes, and the rooms, and the doctor. Open heart surgery. Bariatric surgeries, okay. So, correct, the dialysis. Patient will be paying for per month for rest of his life. Oh, if it gets operated at Singapore. Yeah, but dialysis is probably the costlier also, because patients will be undergoing dialysis till the time they are alive, right? And those patients will be requiring recurrent hospitalizations, infections, other systemic troubles. So that's why probably for me, it is probably the bigger challenge. Heart transplant, heart surgeries, probably that can happen at one time, right? It doesn't happen every year, but dialysis is costly over a period of time. Sorry, not Sensex from last week, but this is how the kidney disease progress. So initially we see that the creatinine will not start rising very fast, but that is just how the exponential curve of creatinine rise will be. So initial time is the one where we should target and try to prevent the further worsening of the creatinine. Otherwise, when the creatinine starts rising exponentially high, even though we try to intervene at that time, we will not be getting full success, and we will be still seeing the patient progressing at the max slowly, but still they will progress. The next thing is very essential. Tobacco, nicotine, kidney. Most of the patients, they do accept that they smoke or they are having tobacco, and they, even though we ask them, they try to say that we'll stop from the next week, and that next week never comes. But that still causes the progression of the kidney disease also. So we need to make sure that we need to say that today is probably the last day that you are taking this cigarette or you are having tobacco. And if you want to help your kidneys, make sure that you are not having it again. The success rate to convince that is very less, I should say, but still we have to try, right? Protein loss in the urine. We need to understand that we need to check our patients for how much proteinuria they are having, because by decreasing the proteinuria, we can decrease the progression of the kidney disease. And in any ways, proteinuria, if it is significant, is no way that could be normal or can be tolerated. So make sure that patients are getting evaluated for their protein loss and getting treated if at all there. Anyone knows what is this? This is called as, where is Waldo? So there is someone like a Waldo who is always hidden, and we need to find out where he is. So in this, the Waldo is here, okay? And that needed like good observation, and that is all what we need to find the signs in our patients also. If they are having small swelling, if they are getting breathless on exertion, they are not able to climb the stairs, they are having loss of appetite, they are losing weight, their urine is not looking good, their urine is having blood or froth. So all these small signs which we need to catch in our patients so that we'll be able to help their kidneys in a better way. The next is my favorite topic, is sick day medications. We need to tell our patients that if they are not well, there are some medications that they should not be taking, or at all they want to take, they should talk to their doctors. And that's something that is very essential for the good kidney health of them. So here are 4 options: AC inhibitors or ARBs, diuretics, metformin and NSAIDs. So what could be a sick day medication? Yes, madam. AC inhibitors and ARBs. Yes, correct. Anyone else? All correct, exactly. So all of them are sick day medications. the meaning only sells everything, that if you are sick, that probably means that you are not hydrating yourself. If you are not hydrating enough, and if you still keep on taking these medications, probably instead of helping, you will affect your kidneys in a harsh way. So stop these medications, diuretics, SC inhibitors, ARBs, SGLT2, dapagliflozin or empagliflozin, NSAIDs, metformin, and you should recover or restart these medications only when your hydration is either good or the doctor allows you, or you are out of your sickness. Recently, I met a patient who was having 5 prescriptions from 5 doctors, and of those 5 prescriptions, I could see 3 diuretics and 4 antihypertensives, which are of the similar groups. So I asked patient, "Ka re baba, काय झालं? 4 डॉक्टर 5 डॉक्टर आणि सगळ्यांकडनं तेच गोळ्या घेतोयस." So no, I was taking second, third, fourth, and fifth opinion. So I said, "Good, but are you taking only one prescription or you are taking everything?" So he said that, "Sir, 5 ओपिनियन घेतलेत, 5 ठिकाणी पैसे दिलेत, 5 ओपिनियन मिळालेत, 5 ठिकाणावरून गोळ्या मिळाल्यात, का नाही घ्यायच्या?" So obviously patients don't disclose that what all medications they are taking. So that could be having a drug interactions. There could be like same drug which could be repeating, and obviously that will affect the kidney in a bad way. Anytime patient asks you about the protein intake and how much or what to eat, because I do get these questions daily, and what should be the answer? I'll give you 3 options. First, कि eat as much as you want, दिल है के मानता नहीं, ले लो जितना चाहिए. Second, no, you should not even touch. And the third one, yeah, you can take sometimes, you cannot, kabhi haan, kabhi na. What should be the answer? So I try to play safe. I gave a partial third option. I say that as per your kidney stage, we should be giving you the advice. So normally, if there is advanced kidney disease, we still give 0.6 to 0.8 grams of 0.6 to 0.8 grams per kg per day, and that will be sufficient that patient not to get malnourished. If we say that 0 proteins, probably we'll see that patient is coming to us, but every time he is losing some muscle mass and getting malnourished. So yes, proteins needed, but we need to choose which one. Better not to have like something which is like more acidogenic animal proteins, but yes, plant source, yes, and definitely 0.6 to 0.8 only. The next is vaccines. Kidney patients, family physicians can suggest them or like advise them to have vaccines. There are 4 vaccines at least they should be targeting: influenza, pneumococcal, shingles, and hepatitis B. These vaccines will reduce their hospitalizations, mortality and morbidity, and the recurrent hospitalizations, if they are lesser, obviously the kidney damage will be lesser and the renal function could be preserved. So yes, even though we are aware of the adult vaccines, we should be at least targeting 4 of them. So suppose someone wants to buy a Honda Civic, what is the best way to buy? So first take a small Mercedes or smaller BMW and then a big BMW and then to go for a Honda Civic, or he can directly go for Honda Civic. What is audience poll? No audience poll. Direct? Yeah, but that doesn't happen with the kidney disease. Our patients get temporary line first, then perm cath, and then fistula. And probably getting a fistula would have been like much more easier and better for the patient and much more even cost effective than. But just that they are not aware or they are not educated enough to have the access preparation, they don't get that much. And after that, all these they come to us and we are here to discuss the dialysis. And the moment we utter the word dialysis, this is the reaction. The family members, mother of the patient, father of the patient. And we are not even able to like enumerate the types of dialysis over there, because they say that no, it's, how can you say that dialysis is an option? And we said that yes, I understand it's harsh, but we still need to consider, because that is the only way we can save your patient. The last couple of things, better we should not delay too much for our patients to reach these stages. Too drowsy, other organ complications, too pale to work, too much of fluid overload, or even uremic signs and symptoms. So better we should intervene early. Definitely dialysis is much more healthier option than patients suffer all these things. What they need is more probably empathy, because if we are in their shoes, probably will not be able to understand. They are going through financial troubles, they are having recurrent hospitalizations, they are not having appetite, they are not able to eat and have taste of anything that they like. They are recurrently admitted, infections are common, they are not allowed to eat most of the things because of our prescriptions. They are taking many tablets, so probably the winners will be nephrologists if the longest prescription writing contest, right? No one can beat us, right, Sagar? Nephrologists can write the longest prescriptions. I have seen 34 tablets. Anyone has seen more than that? No? So that's why. Last slide. So, and the last thing that if they are in reproductive age, they see fertility issues, and in pediatric we see growth hazards. So take home message here, yes, we need to control the blood pressure, which is must. Other comorbidities we need to address. Make sure that we educate our patients for the complications about CKD. They should not take nicotine in any form. They should be aware of sick day medications. We should try and rule out and cancel most of the multiple prescriptions. They need to have restriction of protein, and they should be aware of vaccines. We should prime them for renal replacement, either dialysis, transplant, and access for the same in early stages. They should understand lifestyle modifications, and we should be empathetic to them. Thank you so much. Thank you. Sorry.
I'm sure we all know when to refer the patients to Suhas.
Thank you.
Thank you so much, Suhas. May I request the chairpersons to please felicitate the speaker. So please come in the center. Requesting Dr. Zine Patil sir, the President of Shivajinagar Doctor Association, to felicitate our chairpersons. Ladies and gentlemen, please put your hands together and fill the air with cheering. Tons and tons of appreciation for each one of us present here this morning for this mega event BMACon 2024.